Thank you, as always, for inviting me back. I must be doing something right. I know I kind of talked about the nuts and bolts of addiction last time. And so for the second part of this, what I usually talk about is how addiction affects our community members, and then move into some of the maybe less addiction specific stuff, but some of the advocacy work that I do. I know when I was in training all the way through my fellowship, I didn't really, never thought that I'd be doing advocacy work in the first place. So never really learned much about it. I don't think people really talked about the role of a physician in the advocacy world. So I usually kind of spend the second half sort of talking about how I got into advocacy and potentially some exciting opportunities at the state level right now. I'll mention as well. As always, I try to keep an eye on the chat. I'm not always fantastic about that, but if you want me to pause or stop, or I'm just missing the mark and this isn't what you guys want, and you'd rather just have a discussion, feel free to stop me. In the olden days, when we didn't have kind of the cross institutional collaborations for these lectures, I used to come with whiteboard marker. And we would do like a old-fashioned chalk talk to make sure that it was relevant to you all as learners, because you come at it from a different lens and have different questions. So always feel free to stop me. It's actually like more fun when you do for me. So don't feel like you're interrupting me. I really enjoyed having questions and having some dialogue as we work through. So one of the big things with people with a substance use disorder is about 70% of them have some form of a history of trauma. Having an ACE score of 4 or above increases the risk of a substance use disorder by 12 times, which is a huge amount. It's one of the biggest impacts that ACEs have on a person's health care. I'm going to go through some older studies. They're called the Rat Park studies. And if you Google search Rat Park cartoon, you will get to a series of it's like 50 some, I think it's 56, but don't quote me on exactly the number. Just animation cells that go through these studies. It's a real quick flip book type of read, that kind of goes through a little bit more detail. But I'm going to talk about a series of studies that were done actually back in the 1980s. So they were mostly done around cocaine, and then have been kind of redone and shown to be, essentially the same results with other substances of misuse, inclusive of opioids. And what this guy did, his name's Bruce Alexander. He is at the University of British Columbia out in British Columbia. Sorry about that. That was a little awkward. Out in BC, and what he did was he put rats alone in a cage, and he gave the rats two choices. He gave the rats the choice between water that had cocaine in it and water that was plain. And what he found was that the rats used the cocaine water to the exclusion of other things, inclusive of eating. And so rats alone in isolation preferentially went to cocaine to the point where they overdosed on cocaine or otherwise died of malnutrition or consequences of kind of that desire and that need and that drive to use cocaine. Um, and and uh, and so what we took from that was really the lovely Just Say No campaigns of the Reagan era. And what we thought was that if somebody's exposed to a substance of misuse, that they'll use it until they overdose, because that's what we sort of saw in this animal model. And so what Dr. Alexander did next is he said, well, part of the reason we use rats as human models and not other animals is because, I mean, look how cute that little guy is because rats are social creatures. So they mimic the social nature of humans. So he said, I wonder what happens if I put rats into what he coined as Rat Park, which was essentially a cardboard box that was, as I like to put it, rat paradise. And what it had toys, it had tunnels, it had friends, it had other rats to mate with, it had all the cheese a rat's little heart could desire. And what happened was, uh, and he again gave them the choice between the cocaine water and the plain water. And what happened was, while there were many rats that tried the cocaine water, the majority of rats preferentially went to the plain water and didn't use the cocaine water. Now, there were some rats that developed a substance use disorder and did use the cocaine laced water. However, the majority of them didn't. So there was something about Rat Park that was different, something about the rat having community and not being in isolation that made them feel differently. Now, we've had a couple different human experiments related to that. So, this is just what I said. And there's a like a little screenshot, probably not totally legal, like it's probably copyrighted, but there you go. That's what the cartoon looks like. Like I said, it's easy to go through. In a similar time period, we had something called the Vietnam War. And what we know is that during the Vietnam War, about 20% of soldiers used heroin while on duty. And so when the war ended and we were looking at this massive number of soldiers coming back to the United States, we were very concerned about the capacity to treat substance use disorders in the VA. So there was a lot of concern for reintegration given their clear addiction. So what we did was we said, we're going to bolster the support systems in the VA. And to this day, the VA in the United States is the largest provider of addiction-based care in the United States. So we have this legacy effect that has come forward, which is great because there's not enough care for people with a substance use disorder. But what happened to those soldiers was a little unexpected. 95% of the addicted soldiers, 95% of that 20%, discontinued use after returning home without treatment. So I like to ask the question, is that the human rat park experiment? And we saw similar trends in 2020 when we had the shutdowns. We had huge spikes in opioid overdose deaths. We had huge spikes in alcohol use. We had huge spikes in other illicit substances as people were placed in isolation and by out of public health concern, but there were some unintended consequences. Meanwhile, let's go back to our friendly rats. What Dr. Alexander did next is he put the rats alone in a cage with a drug for a period of about 57 days, which is about how long it takes for a rat to start displaying those behaviors that we use in the animal model of addiction. And then he took those rats and he put them into Rat Park with rats that had been raised in Rat Park. They went through withdrawal, but like our human counterparts, they ended up reducing their use, and this one was done with opioids and avoiding the morphine. But in general, consumption rose then compared to the rat park where every rat was born and raised in Rat Park, but it was less than the isolated rats, and there was fewer deaths. So what is our human life? So what is the human translation of this? So people who are prescribed short-term monitored amounts of opioids for injuries do not necessarily become addicted to heroin. It's not an exposure to result. We used to talk about things like cannabis being what we called a quote unquote gateway drug. We know that that's not true. We know that what we see in reality is that cannabis use or alcohol use or other substance use during adolescence is a marker for a risk-taking behavior. Children who are willing to use cannabis, to use a substance while in adolescence, are taking a risk. They know they are taking a risk. A child who displays that risk-taking behavior earlier in adolescence is more likely to show other risk-taking behaviors as they get older. So it's really that risk that we are marking with early onset substance use. Now, for those of you who were here last time, and for anyone who wasn't, just a quick reminder that the average age of first use is between 11 and 13. I just told you guys that I have a 13-year-old. I also have an 11-year-old. I think about this a lot in terms of keeping them safe, keeping their exposures down, and trying to build a rat park in my community, in my children's lives, so that they have those protective mechanisms to prevent them from moving towards substance use. We know in the prevention literature that the most effective form of prevention is not a single school-based program. It's not DARE, it's not Project Charlie, it's not any of these programs that maybe some of us grew up with. I may be dating myself. But what it is things like Boys and Girls Clubs of America, places where kids can go for social connection and social support, help with homework, pick up games of basketball. What it is not is the overscheduling and pressure that we currently put on adolescents. Being involved in sports is a risk factor for binge drug use. When do they binge on the drugs? They binge on the drugs in celebration after a big game. So, what we actually see with the pressure that we put on adolescents right now to perform in high risk games, in high risk environments, is increased substance use. So, what we want is we want Boys and Girls Club of America or similar programs integrated into every school in the United States, integrated into every community, so that there is a sense of purpose for the adults that are supporting those children, and so that there's a safe, low barrier, low risk environment for children to have health and wealth. We know that the social marker of increased risk is that isolation. The average person has in their lives, sorry, the average person with high safety profile for general mental health well-being has 5 people in their life that sorry, my computer, I just had to ignore some updates as one should, right? I don't know if you saw that pop up, but it distracted me. What has about 5 people that they feel are individuals that they could call at the drop of the hat if they need help, if they need support, if they want to celebrate something. They have 5 core relationships. People who have fewer than 5 core relationships have an increased risk for mental health and substance use disorder concerns. So all of this, and what we also know is the connection that we feel over Zoom, the connection that we feel without sharing kind of 3-dimensional space with people is way reduced. Look, I don't even know if anyone's paying attention. I don't even know if anybody cares that I'm here. I could be talking to a bunch of people who have me muted and watching the YouTube videos right now, because I'm not even getting any feedback from other humans as I talk this morning. And that's a product of some of this technology and some of this technology age. Now, I have a parent who lives in California. I live in West Michigan. Having the ability to video conference and Zoom with him has helped him stay more connected to, my children as they grow, myself, right, be involved in our family in a way that maybe wasn't possible without cameras. However, my children have a very different relationship with that set of grandparents than they do with my husband's family because they live a 30-minute drive from here and we see them on a regular and consistent basis. And so you can probably pick out relationships similar to that in your own life and thinking about those 5 people that you have that are your people that you think of when when you matched into fellowship. Who did you think of to call? Who were the first people on your list that you needed to make sure knew that this had happened? So I talked about so what we think some of the issue with all of this technology connection is that we're actually experiencing what I call a human interaction isolation. We're not getting the feedback in the human interaction that we once did because we spend so much time on screens, and it's a lot easier to depersonalize the person on the other end of the screen when you're not in the same room. Having the same conversation in the same room is much more difficult. We as humans have a need to bond and form connections. You guys see this all the time in your work. If we cannot connect with each other, we'll connect with other things that give us satisfaction. We'll connect with other things that take away the pain of a lack of human connection and a feeling of isolation. So the opposite of addiction is actually human connection. This is like one of my favorite quotes in all of addiction medicine. Ooh, I missed an end quote there, but it's for too long. We have talked exclusively about individual recovery from addiction. We need to now talk about social recovery, how we all recover together from the sickness of isolation that is sinking on us like a thick cloth. I want to be clear that this quote is not from COVID. This quote is over 15 years old. We've been on this path of individual destruction for a long time, particularly in North America. One of the unique things about North America is we are a country that is predicated on this concept and this idea of the individual. The American dream is not based on bringing up your community, bringing up your family. The American dream is based upon you doing work, you as the individual to be successful. If you work hard enough, you can succeed. If you put in the hard work, you can succeed. If you do it, then you will have the house with the white picket fence, the dog, a cat, and 2 kids. In other countries, if we look at some of our European counterparts, the unit is the family. The unit is that it is the family inclusive of like grandparents, parents, and children. And so what we see in Europe is kind of this focus on family, which reduces the amount of isolation and increases that human connection. What we see in kind of our Southeast Asian and Asian communities is that the unit ends up being the community. It ends up being broader. We also see this in our African communities, and traditionally we see lower risk behaviors when it comes to substance use in communities where there is less isolation. Okay, let's talk about advocacy. Now, if you had told me when I was a fellow, when I was a medical student, even in the first few years of my practice, that I would be standing here in front of you today talking about the Michigan Opioid Advisory Commission as the chair of that commission, I would have told you that you were absolutely crazy. I just wanna, wrong way. Okay. And so I'm going to go through, I thought I did in that order. Sorry about that. I'm going to go through what the Opioid Advisory Commission is, what it does, and what opportunities there are there. And then I'm going to talk a little bit about kind of how I got into this role and into this position. So then there are national opioid settlements that are across the distributors, developers, and marketers of opioid pain medications that total billions and billions of dollars. Michigan is slated to receive about $1.6 billion in this settlement. Michigan is Attorney General. Each state kind of is structured a little bit differently, but for us, our Attorney General's office negotiated a 50-50 split. And what that means is that 50% of that money goes directly to the counties, townships, and municipalities that signed on to this litigation. And then the other 50% sits at the state of Michigan. The Opioid Advisory Commission is a nonpartisan group of 12 individuals that's appointed by a combination of the legislature and the executive branch that advises the legislature on the appropriation of those state dollars. And so we are currently in our third year. States are kind of still in the process of implementing and developing the administrative structures to disperse the 50 billion that was awarded across the United States. If you notice, we're receiving 1.6 billion out of 50 billion. Part of how this calculation happened was not only population, because we are not one of the most populous states, but based on not only population and also the amount of devastation that hit the state of Michigan. To put that into perspective, here in Michigan, one person dies of an opioid overdose about every 6 hours. That's 4 people a day. That's over 2,000 people a year. Now, the addiction world has done a really poor job of kind of saying and describing the impact of our disease space. That's like saying the only cardiovascular causes of death we're going to count in terms of hypertension are people that have a stroke from hypertension. We're going to ignore all the people that have an MI. We're going to ignore all the people that have renal infarcts. We're going to ignore all the people that have any other cause of death from hypertension other than strokes. So we do so the impact of opioid use disorder alone is actually much greater in terms of just that kind of terminal late stage outcome of death than what we actually talk about. And when we look at alcohol use, we've seen the last statistics we have, which I believe are 2022, are 178,000 people in the United States, nearly double what died of opioid overdose in that time period. Died of alcohol-related causes. So alcohol actually kills way more people than opioids do in any given year. So here's what the OAC is supposed to do. We're supposed to review strategies. We are statutorily obligated to develop a needs assessment, which I will come back to support the legislature on an annual basis and to report that out. And that is what we're supposed to use to make our recommendations for how to spend the state dollars. We report directly to what they call in Lansing the Quad, which I didn't know what that meant. So what that means is look, people turn on their cameras. It makes me so happy. It means the Senate Majority Leader, the Speaker of the House, and their minority leadership counterparts. So the minority leader of the Senate and the minority leader of the House. So that's who we report to. We also send our report, as might be obvious, but to people like the Public Policy Committee, the committees on both the House and the Senate side, as well as the appropriations committees and their subcommittees as appropriate and relevant. The Senate has a little bit, for us, a simpler structure. Where there's one DHHS appropriations committee, and this funding thus far has gone through the DHHS process. Whereas on the House side, they have 3 committees that kind of deal with behavioral health and addiction that occurs within DHHS. So we have a little bit broader reporting responsibilities in terms of numbers of people we're supposed to share this information with. So we are statutorily obligated to do a needs assessment and utilize that needs assessment to report to leadership, to develop the goals and recommendations, and to recommend funding and recommend policy opportunities. Um, these are the two public acts that Public Act 84 created the Opioid Advisory Commission, and Public Act 83 created the fund, the Opioid Healing and Recovery Fund, where the money sits. These settlements are a little different than the tobacco settlements, where they have Exhibit E, which essentially is allowable uses of the fund, and there is a limited amount that can be utilized for non-opioid remediation based work. The money can be used for opioids, broader substance use, and mental health concerns across the state of Michigan. To date, we have over 200 million that has been deposited into the account. The OAC has been working hard to develop a relationship with the Michigan Department of Health and Human Services. The governor has a separately appointed task force, and they are supposed to be advising her on the appropriation of these funds. In all fairness, that relationship has been sticky at best and antagonistic at worst at different times. As chair of the Opioid Advisory Commission, at one point, my funding was I receive state dollars for some of my work because I'm employed by MSU and contracted back to Trinity Health for my clinical time. At some points, my work has been threatened based on the recommendations that I've made. We're in a much better space with the department at this point, where at least they are sharing their strategy with us. Although we would like it to expand and be a little bit more meaningful. We think there have been some pretty promising developments this year. We are also statutorily required to create an annual report, which is open and available to the public. I will be leaving from here to drive to Lansing with a pit stop at 9 a.m. to take a Zoom call with one of the legislative offices to let them know about our recommendations, and then proceeding on to the Opioid Advisory Commission meeting. Open Meeting Act requires us as commissioners to be there in person with a quorum of 7 individuals or more. However, the meetings are available via Zoom if anyone is interested in attending them. We do reserve time in each of our meetings for public comment to hear about how we might be able to consider individual or things that maybe our group of commissioners hasn't considered in the past. We really have centered our recommendations and our work around what is considered the national best practices, which are the Johns Hopkins Bloomberg School of Public Health Principles for the Use of Funds from Opioid Litigation. And we kind of refer to them as the spending principles. So here are what they are. We want to spend money to save lives. We want to use evidence to guide the spending. We want to invest in youth prevention, focus on racial equity, and develop a fair and transparent process for deciding where to spend the money. Principle 5 is where the Opioid Advisory Commission has spent a significant amount of our time ensuring that there is public accountability and availability of information so that the public knows where and how these settlements are where and how these settlement funds are being spent. We talked a little bit about youth prevention and the importance of using evidence to guide spending. I hope I don't have to convince too many of my physician colleagues that we don't want to participate in, snake oil type equivalents as we come through. It is remarkable to me how many emails I get as the chair from companies that are like, we have this magical product that's going to solve all the problems of your universe. There have been you can look in the news. There have been Ibogaine is a plant-based product that there's a company that has been soliciting different states, and I got outreach from one of our legislative office saying, have you heard of this? If you Google search it and you look at and you look at what happened in Kentucky around that, it's remarkable. It's like so much fun. This is so like how I like to spend, my Saturday nights. But kind of looking at all the people that see that kind of big dollar amount and are kind of putting their hands out looking for money. So we want to make sure that we can back up all of our recommendations with concrete evidence-based practices or promising practices that that we think have a lot of future potential. And of course, the first principle is to spend money to save lives. We want to identify through a gap analysis what those needs are and how we can best support them. So we have 4 buckets that actually the Department of Health and Human Services adopted in their current opioid strategy. So there's some good alignment there, which is wonderful. And they're prevention, treatment, recovery, and harm reduction. And so ensuring that what we are doing has metrics related to each of those areas and that there's a equitable distribution of the funding to ensure that we are using the funding in a way that is effective and requiring that reporting back on how those dollars are used and what the impact was so that we can continue to kind of PDSA the way that we are using the funds. These are the Opioid Advisory Commission's guiding principles. So this is something that was developed in-house by our commission as kind of the key things that we would like to see that we kind of consider when we make our recommendations are the programs, the projects, the evidence showing that if we invest dollars in this type of prevention, is it going to have effects in these domains? So we really just want to enhance collaboration and increase legislative oversight and ensure that that we are getting and receiving information from the department. We have a community engagement and planning committee collaborative that's run by the staff person at the OAC. We've done some regional listening sessions over the last couple summers when legislature is on break and goes back into the communities. Michigan's legislature is a little unusual in that we run a 12-month calendar. There are some legislatures in the United States, some states that the legislature is only in session for 4 or 5 months out of the year. So we do take a summer break for our legislative officers to be able to go back into their communities and hear from their community. If you hear about town halls, if you hear about things like that, it's a really great way to get engaged. Representative Skolton, who's not state legislature, but our federal representative, is holding an in-person town hall tonight. If anybody is interested in attending that, you can probably find the information, but I can also share it with Susan and Dr. Mulder if that's of interest. But it's when one individual reaches out to the legislature, it counts for 10,000 voices. That's how few people traditionally reach out to legislative offices. So whatever your political opinions are, whatever your advocacy desires are, wherever you want to focus your energy, just remember you are speaking for thousands of your fellow citizens. And as people with sort of, as I like to put it, shiny letters behind our names, meaning we have the degrees, we have the clinical acumen, we are PAs, we are NPs, we are MDs, we are DOs. Our voice matters, and we are listened to in sort of a different way than maybe some other people are. So that's a lot. I do a lot at the state. And sometimes I've learned that it can be overwhelming because people are like, oh my gosh, like you do all these things. And I'm like, yes, I do all these things, but I didn't always. So I want to spend a few minutes just chatting about how I came to what I do. So I'm an internal medicine physician by background, and I had an experience in my residency where my attending essentially did motivational interviewing, and I wanted to learn how to do that technique. And so I went to a conference where we really practiced motivational interviewing and learned the principles of that, but also learned the principle. It was based in an addiction group out at Boston Medical Center. The program's still running. There's a chief resident immersion training that they do, and there's actually a fellow immersion training that they do for incoming fellows. So maybe something to think about for next year's cohort, where they do training in addiction, and they do training in motivational interviewing. And I just really liked motivational interviewing, and so I kept kind of getting assigned to the addiction clinic that was embedded within our residency clinic. My program director is an addiction medicine physician, so we definitely had more than the average residency. So I ended up going to this conference, applying to addiction fellowship, going to Boston, where Boston has like all the things, all the things. They have all the resources. And while I was in Boston, I moved to Boston about 10 months after my mom died. And while I was in Boston, my brother died. My brother died of a self-inflicted gunshot wound related to his significant alcohol use disorder and comorbid depression. That's mom, and that's Max next to her. And it really kind of changed my perception as an addiction physician, right? Sometimes those personal experiences have a way of kind of making you pivot in different ways. So I like to say I was becoming an addiction doctor. I loved the field, but then there were obviously some family relationships that had some substance use in them. But it wasn't until I was really in my fellowship that it became sort of something that I became what I live and breathe. From my experience with my brother, I kind of grew my purpose when I moved back to Michigan. Again, in Boston, they've been kind of an epicenter of the addiction crisis for many, many years. And so they have a lot more infrastructure and support. And when I moved back to Michigan, I found that there wasn't a lot of infrastructure and support. And so I found out that Michigan's Medicaid actually at the time, this is 2013, did not cover seeing a prescriber, like a clinical office visit for somebody with a substance use disorder. And every day I will wonder if my brother, who lived in Michigan, and if he had been offered medications and evidence-based treatment to treat his alcohol use disorder, if he would still be alive. And so my purpose is to ensure that every single person that has a substance use disorder is offered evidence-based treatment. We know that alcohol medications to treat an alcohol use disorder reduces the rate of alcohol, puts about 30% of people into remission from their alcohol use disorder. We know with opioid use disorder that somebody who receives either methadone or buprenorphine has a 50% reduction in the outcome of death. No other treatment, not all the counseling in the world, not naltrexone, not the opioid antagonist, reduces the outcome of death in opioid use disorder. So if somebody comes in with an opioid use disorder and they are not offered buprenorphine and methadone, then you are increasing their risk of death. We are not reducing their risk of death. The risk of death, again, is reduced by 50% by prescribing medication, yet less than 10% of people with DEA licenses to prescribe controlled substances prescribe buprenorphine. Methadone has a different sort of regulatory infrastructure, so we don't have, so that kind of is excluded from that data. So I started speaking publicly about Max, about my mom, about my story, and how I got into this space. And I would talk to people at DHHS. I didn't really know what I was doing. I started by calling like provider relations because I was like, this can't be right. And what I found was that actually, really, we didn't have coverage for that. We just didn't cover seeing a physician. So no wonder no one did it. And those people that did it were cash-based businesses that charged patients like $200 an office visit. Again, this is 2013 to see a physician to get a prescription that was not always covered by insurance and requires significant prior authorization. So many of these cash-based practices just didn't do the prior authorization, which meant that the patients had to pay cash for the medication. On top of that, federally, we had limits, they've been eliminated, on the number of patients that we could treat. So we just couldn't treat patients. So I didn't understand. I didn't get it. It didn't make sense. We weren't helping people. And so for 7 years, I kept talking about it. So 7 years, right? Never give up. I kept talking about this. I now refer to it as my 7 years war, but which was a war of territories. And why I like to use that analogy is because in Michigan we have a behavioral health carve out. That's why we have a CMH system. We're one of only 3 states that has a behavioral health carve out. There, we don't have to have one, but we do. And so the behavioral health carve out people said it's not in our purview to cover. We don't have a way to reimburse physicians, and the HMO, the Medicaid products, said that it was substance use disorder, so therefore it was supposed to be covered by the behavioral health carve out. So nobody wanted to cover it. So after 7 years, Medicaid updated a policy to cover a prescriber level clinician seeing a person with an alcohol use disorder and an opioid use disorder. Now you can see the bullet points, they covered some additional services as well. But they still left out a lot of SUD diagnoses. Their logic was there aren't medications to prescribe for those, so you don't need to do that. Because I have no value as an addiction specialty physician other than the prescription pad that I write on. Well, that I click in, I don't know what I'm supposed to say there. Other than my prescription, my prescriptive authority. That's literally what they said. It only took until January 2024 to get them to update that. They also finally expanded that to cover inpatient addiction services as well as recovery coaches. So it took a long time though, right? It took 7 years from 2013. So here we are 12 years later, and now I'm the chair of the Opioid Advisory Commission. I also, I think I'm going to skip some of those. Okay. I also chair the Advocacy and Public Policy Committee at the American Society of Addiction Medicine. So like I write policy for the nation that is used not only in state advocacy, but in federal advocacy. I also am I'm the incoming vice president for that society. Our conference is next week. So at the end of conference, I'll be vice president of that society. But none of that would have happened if I hadn't started kind of on the side advocating because something just didn't make sense to me in medicine. So the reason I like to go through that whole story is because sometimes people see what I do today and they don't see where I was when I finished my fellowship. They don't see where I was 5 years ago when I was still talking about the same thing and nothing had perceptibly changed in terms of our practice here in Michigan. So I think it's really an important thing to engage in. Not everybody has to become the chair of some random, government committee. But you can do advocacy at the local level within your institution, updating policies. If something's not making sense, if you are concerned about your patients, then we need to speak up as the heads of healthcare teams, as the person that a lot of the other team members are looking to support them and to make sure that they have that we have the tools and they have the tools to provide the best quality patient care that we can. I end all of my talks to all the people who've lost their lives to addiction and those that try to prevent further losses. I know this was a little bit of a different talk than maybe what you've received in the past. Please feel free to reach out to me. My email is there as well, and I am happy to entertain questions for I did it. I left a few minutes. Last time I failed, and I apologize for that, but I left about 8 minutes for questions. Also, I know sometimes these lectures are back to back, so if we just want to take a break, that's okay too.
Well,
Thank you.
let's go ahead and open it up. I just continue to admire the work you do, and I know that with the passion and the wisdom and the background you have, there's a natural frustration at not being able to see results quicker. I look at that 7 years and think that's pretty darn remarkable to accomplish what you've accomplished in 7 years, quite frankly. And the difference that we can see, I mean, the news last, just 2, 3 weeks, we're touting the significant reduction in opioid deaths in the state of Michigan. And I think very appropriately are saying, okay, now that we're succeeding in that objective of reducing deaths, what do we do to help these people that are not dying anymore? Because they still have illness, they still need this social structure, they still need community, they still need treatment. And I think that there's a sense of just kind of wiping their hands, mission accomplished, not you, but a lot of folks that don't understand, wiping their hands and say, good for us, pat us on the back, and now we'll move on to roads or something else. I don't know, but and so this work is important and it continues, and we are grateful to have you on the front line. So those are my comments. Questions for Cara?
Cara, who's on this 7-panel board of yours?
So there are 12 of us, but we have to have 7 physically in person to conduct business. It's a combination. There are a couple of people that are in recovery. There's a retired judge. There's a former representative. There are CEOs of there's a CEO of a residential treatment program out in Detroit. There's the executive director of a recovery community organization. The executive director of Families Against Narcotics is on there. Face Addiction Now, sorry, they changed their name, is on there, as well as the executive director of the national, of our state chat, the Michigan Association of Drug Court Professionals. We also have a sheriff who's on it. We have a prevention specialist who's from University of Michigan, as well as a PhD level trained epidemiologist. So it's a pretty wide variety. I have been, frankly, a little disappointed recently that the majority of the more recent people that have been appointed are all from Southeast Michigan. We literally have nobody from the upper half of the Lower Peninsula or the Upper Peninsula, which I think, is not great. We also have a gap in harm reduction. My term ends in July, and when I roll off, there's nobody with prescriptive authority on the board, which obviously is concerning. But it's they're appointed by the legislature, and from what the vantage point I have, I'm not sure there's a strong coordination or collaboration across offices in terms of choices and who they're appropriating, or in choices of who they're appointing to the commission.
My experience in state commissions, David, are that they have typically what it looks like on paper, and as she's reading those names, you say, that makes a lot of sense to have people like that on these types of commissions.
It did to me, but I don't know. Yeah.
The problem is they don't always play well together in the sandbox. People come with their different agendas, and they come with their different perspectives. But the opportunity to parlay that into meaningful outcomes that can be understood, interpreted, and enacted by the governor and by the legislature and by even licensing agencies and the dealer and stuff like that. You've got these other people that don't know what to do with this information that the commission is coming up with. I don't know. I don't know what your personal experience here. That's what I encountered.
Yeah.
That's,
I think the other challenge that we've had as the Opioid Advisory Commission is the state legislature for the last 3 years has the first year they just appropriated like a literal blank check to DHHS and was like, do what you guys want to do. And then in the last 2 years, they've
Right.
also given some direct appropriations to specific programs. But they have not really we haven't been funded to do a needs assessment. And so without a needs assessment to identify the gaps as is statutorily required of us as the OAC, and make recommendations based on gaps, it is a bunch of experts sitting around a table going, well, should we make recommendations based on like what we think? And the commission to date has determined that that would not be the best way to do things, that we should be using evidence to guide our decisions. However, we are currently advocating for three things: short-term, medium-term, long-term. Long-term, an endowment of $10 million a year to a total of about 10% of the opioid dollars that come into the state. There are currently 200 million sitting unappropriated in a fund. So we would like them to start appropriating into an endowment that could then be drawn on, because we all know there's gaps in healthcare. There are going to continue to be gaps in healthcare well beyond the settlement duration, which is 15 years. And then medium term is if they are choosing to appropriate to specific organizations, the OAC has requested that they require those organizations to report back to the OAC on deliverables, to have identified what the gap is that they're filling, that is guiding their choice in deliverables. And then finally because there are local dollars going to local communities, to ensure that statewide dollars are going to programs that have an impact regionally or statewide. And then as you can probably imagine, the short-term recommendation is, yep, you guessed it, a needs assessment. However, if the needs assessment is not funded, then there has been discussion amongst the commission that we may have to start making more concrete recommendations without maybe the data and evidence that we would like to have. So if you want to know what can I do, I put in the legislative council website into the chat. It has a list of all of our members and our community documents, but write your legislative offices, write your senator, write your representative for the state of Michigan, and tell them that this matters to you. Tell them that you're a physician and you want them to work with the OAC. And that would be meaningful and impactful for those of you for whom Winnie Brinks is your senator. She is the Senate Majority Leader. She has not met with me once in my role as Opioid Advisory Commission Chair. So maybe email her office if you are her constituent and express how important the safe, appropriate utilization of these dollars are.
And it doesn't necessarily have to be that you're her constituent as
Yes.
your home address. If you are working in her region, she will listen. I don't know if she'll take the meeting, but she'll listen. I've had
The more people that write her, the better, because the more likely it is, because she has to, because we pay her salary.
Yeah.
They represent us. So.
Well, as we transition to the case, I just want, one of the really important messages for the fellows here, because you see things beyond even opioid use disorder and alcohol use disorder and the things that are passionate to CARE's practice. You see other things that need our advocacy, that need our support, and you can indeed make a difference. And sometimes it seems trivial because you write your legislator. It's not trivial. In a state in a state like Michigan, I can guarantee, number one, you're going to get a response. It may be a productive response or a non-productive response, but you can push that response then and say, "Thank you for your response. Here is what I would like to do. and you have to also understand that the first meeting you take may not be with Winnie Brinks. It may be with one of her your healthcare legislative aides, which is perfectly fine because she has their ear. And so it's I think it's important. I think it's necessary at some levels that we keep those sorts of interventions on the radar so that we can the voice can be heard, so that what we're attempting to do within our specialty is heard. So
The last thing, just in case folks are interested in an opportunity, of course, I threw my email into the chat. Dr. Mulder has my cell phone number. Susan has my cell phone number. Dr. Rowe has my cell phone number. You get the point. There are 17,000 ways to find me if you are so inclined, now or in the future. But please, please also just be, if folks are interested in maybe an upcoming opportunity over the next few weeks, Senator Hertel, who chairs the Senate Health Policy Committee, is introducing a suite of about 12 new laws around opioids, opioid prescribing. And in the drafts that I see, there are no exceptions for palliative care. There were in previous legislation. So maybe something you all would have some thoughts on, but there may be I can help provide opportunities to provide direct feedback to his office, as well as opportunities to testify in front of committee in Michigan, which is a lot of fun. But I can certainly provide that information as it becomes available if folks are interested. And I'm happy to help people prepare testimony, think through what they want to say, meet with senator's office, because the first couple of times it can be a little daunting, but it's a lot of fun too.
it is fun. Yeah. All right.
Sorry. Thank you.
Thanks so much, Cara. This is always meaningful and interesting. We appreciate your wisdom, insight, and willingness to share.
Anytime. We'll see you all soon. Thank you.